Good evening and welcome to our OncLive webinar, Managing High-Dose Methotrexate Toxicity. I'm Sejal Saraya, Scientific Director with OncLive, and want to thank you for joining us today. With us today, we have Dr. Ziad Khanaan, Medical Director of Oncology from Sutter Health, Santa Rosa, California, and Dr. Laura Ramsey, Assistant Professor, Divisions of Clinical Pharmacology and Research in Patient Services, and also co-director of the Genetic Pharmacology Service at Cincinnati Children's Hospital Medical Center, Cincinnati, Ohio. They will be leading our presentation this evening and sharing their insights on best practices for managing toxicities from high-dose methotrexate therapy. If you are listening to the webinar, we encourage you to submit your questions or interesting patient cases you may have, and our faculty will answer them at the end of the program. So without further ado, I'll hand it over to Dr. Khanaan.
Thank you, Sejal. So this is Ziad Khanaan. I'm a medical oncologist and director of oncology at Sutter Health in Santa Rosa, as kindly introduced. Today with me is Dr. Laura Ramsey. We're going to be talking about the acute toxicity of high-dose methotrexate. So I'm sure you kind of registered for this talk out of interest in this topic. This really is not one of those medical conditions that you're going to see every day. A lot of that owes to the wonderful standards we have in preventing this condition. That said, I think while we standardize our preventative approach, we haven't really done a great job standardizing our management of the condition should it occur. This is a true emergency. So really what we're talking about is, high-dose methotrexate induced acute kidney injury. So the title is toxicity, but we're really here talking about the kidneys for the most part. We've done a great job with managing the acute STEMIs, acute strokes, door to balloon time, door to TPA time. And what I always say in this scenario is that if this was a painful condition or a visible condition such as strokes, it would have gained a lot more attention. So I'll kind of walk you through why I'm saying that. So just kind of wanted to introduce with that. And believe it or not, this is actually a very brief introduction. Typically, I would have moderators tell me your time is up by now. So in our talk, we're going to be reviewing the mechanism of action of methotrexate, definition of high-dose methotrexate, and indications for use. We're going to be talking about the clinical implications of using high-dose methotrexate. So kind of note that we're really talking about the high-dose methotrexate, not the common methotrexate we use in some of the solid tumors. We're going to be talking about the preventive strategies to mitigate toxicities when using high-dose methotrexate. And then we're going to review treatment options and describe the role of glucarpidase in the management of high-dose methotrexate. So I'll give the first half of this talk. Dr. Ramsey will take over, and then I'll circle back toward the Q&A session in the last 15 minutes. All right, so what is methotrexate? We have a wide variety of audience and kind of professional backgrounds. So just to kind of give you a quick impression of kind of how I describe methotrexate. Methotrexate is a molecule that looks to a cell like folic acid. Okay, so it is a chemotherapeutic drug that was designed to look like folic acid, but it doesn't give the benefits of the folic acid, and actually it gives the exact opposite. So really what that means is if you have a molecule of methotrexate floating around and a molecule of folic acid floating around, that cell can be fooled into taking any one of them into the cell through active transport. So then if you use high-dose methotrexate, that means you're just by numbers, you're competing with folic acid by using those high doses of methotrexate, and it will competitively beat folic acid into that cell. Once it gains access to the intracellular mechanisms, the overall approach is by inhibiting DNA synthesis. Okay, so it's kind of as an overview, it inhibits DNA synthesis. Any cell to maintain survival and divide and replicate, it will need to replicate its DNA. If that cell cannot replicate its DNA, it will eventually die. So that's why this is called a cytotoxic chemotherapeutic agent. goes in, paralyzes that whole mechanism to synthesize DNA, kills the cell. That's the cell kill it achieves. So in other words, it works on the S phase of the cell cycle, so the synthesis phase of the cell cycle. But kind of in more detail, what it does is it paralyzes this enzyme called dihydrofolate reductase. So in a perfect world, what would happen is that cell is destined to divide. It'll take in folic acid. Folic acid uses this enzyme, dihydrofolate reductase, and then it is reduced to what we call a reduced folate. That reduced folate is where we get our purines and pyrimidines that are the building blocks for DNA. So thinking about what we just said, if methotrexate is going to paralyze that process, that means these cells are depleted of reduced folates, okay? So if I give someone methotrexate, the cancer cells will be depleted of reduced folates. The healthy cells will also be depleted of reduced folates. So then what you have to do is give the healthy cells reduced folates after you exert the kill so that we can selectively salvage the healthy cells. They will take in the reduced folate and the mechanism kickstarts again. For whatever reason, cancer cells don't take in that reduced folate we give. And that reduced folate is that leukovorin or leukovorin calcium as you know it. So give methotrexate, deplete reduced folates from all cells, healthy and cancer cells, salvage the healthy cells with leukovorin. Cancer cells do not take it up, and therefore we selectively kill cancer cells. So that's kind of in a simplistic way how methotrexate works. So think of it like that, really. So a cell looks at leukovorin, folic acid, and methotrexate as the same molecule. So what's high-dose methotrexate? So high-dose methotrexate, by definition, is a dose greater than 500 milligrams per meter square. Typically, what you see in anti-cancer therapy, if you really want to use high-dose methotrexate, it's common that we kind of start with 1 gram or 1,000 milligrams. But by definition, it's greater than 500 milligrams per meter square. Just to kind of put that in perspective, in some of our combinatorial regimens, like for bladder cancer, for breast cancer, the methotrexate dose is 30 or 40 milligrams per meter square. So that's for solid tumors. This is obviously not the methotrexate that we talk about when we use it for psoriasis or rheumatoid arthritis, where it's, even graft versus host disease, where you use oral therapy. Those are much lower doses. So that's what high dose methotrexate is. The reason we use high dose methotrexate, so why didn't we just create a new drug that has a better effect compared to going up on the dose of methotrexate? The reason is because it works, because it's one of those drugs that you can actually keep going up on the dose to a certain limit, and we have good parameters to monitor, and we can safely give it. But the goal is to maintain a therapeutic level in the plasma of greater than 1 micromole. So if you give a regular dose, you only achieve that 1 micromole for a brief period of time, whereas really for anti-cancer properties for leukemias and some of the sarcomas, you really need it about, I think most would say 18 to 30 hours. In order to get that, we give what we call high-dose methotrexate. And you'll see different protocols, even within the same disease, they can have a high dose given over 4 hours or given over 8 hours or given infusion over 12 hours over infusion pump. And the difference is there, the toxicity profile is somewhat different, but kind of mechanistically or pharmacokinetically, if you give it over a short period of time, you achieve higher peaks. If you give it over a longer period of time, you maintain adequate troughs. If you want a therapeutic dose, it has to be greater than 1. But that's also the toxic dose. So what Dr. Ramsey will kind of explain to you when we go over the elimination curves is our goal is to eliminate methotrexate by reducing it to less than 1. Okay, and then you'll see that kind of the different standards across the institutions there. Leukovorin calcium, as we discussed, is required during treatment due to the additional toxicities to rescue, that's what we call it, leukovorin rescue, to rescue the normal cells. So where do we use high-dose methotrexate? We use it in ALL, and you'll see different regimens. Hyper-CVAD is 1 gram over 24 hours. You'll see it in some of the other regimens of 5 grams. Osteosarcoma doses can go all the way up to 12 grams. So see the difference there. Lymphomas, so mostly we're talking here about primary CNS lymphoma, but you also have secondary CNS lymphomas that use high-dose methotrexate because it crosses the blood-brain barrier. So what happens? So in our title slide, we said, managing high-dose methotrexate toxicity. In reality, we're talking about managing high-dose methotrexate acute kidney injury. So why is methotrexate so unique in that we have to really watch out for the kidney function? That's really because it's not that unique. Cisplatin is similar to it, but because the kinetics and dynamics of methotrexate are probably so well understood, and we have to use these high doses, we're trying to regulate the field. So what happens with methotrexate is about 90% of it, anywhere between 80 and 90%, is excreted unchanged in the kidneys. So you better be sure those kidneys are adequate and healthy so that you eliminate methotrexate. Because if you don't eliminate methotrexate, that's methotrexate in the system. And that's kind of like an overdose. So it's exaggerated toxicities. And some of these regimens we're talking about every 14-day treatments, and any toxicities will delay the subsequent cycles and obviously cause harm. So if you're a floor nurse listening in here or have ever treated patients with high-dose methotrexate, you know that you're not going to start that infusion until that urine pH is greater than 7. So why do we alkalize the urine? It makes methotrexate more soluble. Again, in a simplistic way, if it's soluble, it flows through the tubules. If it's insoluble, it'll crystallize. So as it goes into the tubules, it will crystallize and then just clog them and eventually cause tubule damage. There's another mechanism. That's the major mechanism. The other mechanism is probably oxygen-free radicals and tubular necrosis. But we're really talking about nephrons. So if you want to say, time is muscle or time is brain, in this case, really time is nephrons. And we'll talk about kind of how to measure that. Statistically, we're not really talking about a very common condition, okay? And because it's not very common, you don't really have those prospective studies that give you all the statistics you want. They compare treatments. You won't find that. What you'll find is case reports, case series. There's a good meta-analysis that combined pediatrics and adults. So again, it's not a very common condition, but I would caution you on how to take that phrase. If I tell you it's not a very common condition, that doesn't mean we don't need to get our standards together so that we know what to do when it happens. This is kind of one of those situations where we do such a good job preventing because we use fluids, leukovorin, hydration, alkalization. We use all those preventive measures. But once it happens, I don't think many institutions have really come together on figuring out guidelines, really up until actually like late 2018, I believe, when we have now the consensus guidelines on how to treat this acute injury. A lot of it was based on clinical judgment. So you will see different methods deployed to treat the condition. And not that we're trying to eliminate clinical judgment by any means, but in any industry, when you minimize variation or when you standardize approaches, you do raise the quality of your care. So that's really what we're trying to do here. And if you take anything from this conversation, it's really that, tomorrow's Friday morning, everything happens on Friday afternoon. So just kind of be prepared if you're an institution that delivers high-dose methotrexate. Just see where you have some of these treatments for it. See if you actually have a protocol to treat it. And I think protocols are really what are going to really refine this landscape. The incidence is 2 to 12%. And the reason that range is wide is because, again, it's not common. These are based on case reports. But interestingly, 9%, so kind of the higher end of that range, is in lymphomas. So what that tells you is, lymphomas is kind of an adult disease, okay? And it's not even the highest dose of methotrexate that we use. We actually use higher doses for osteosarcoma pretty much all the time. When you're comparing lymphoma dose of, let's say, 8 grams compared to the 12 grams used for osteosarcoma, the incidence in osteosarcoma is actually about 2%, so on that lower end of that range. So why is that? Part of it is because it's not dose dependent, but I think the bigger factor here is that those are children. Children have reserve, right? They're robust, they're resilient, they can handle it. In other words, adults, just by looking at their GFR or creatinine, you can't really assess how many nephrons they have as a reserve function, and therefore, if they take a hit, the recovery is a little bit harder. So risk factors, there was a study that looked at a group of patients who developed this complication, then went back and said, so what's so special about you? What do you have in common? And really, it's volume depletion, acidic urine, which we really shouldn't be seeing, drug interactions if you're using it with, vancomycin, for instance, for someone who had an infection. You had a patient who's also on a combination with cisplatin. So drug interactions, allopurinol, NSAIDs, previous history of toxicity with prior courses. This is actually very interesting. So a previous history of toxicity with prior course of high-dose methotrexate is a risk factor for future toxicity. This was actually evaluated. There were a little over 1,000 patients, pediatrics, osteosarcoma patients. About 20 of them developed this complication. So then they're due for their next cycle. So what do you do, right? So they developed a complication, they got their glucarpidase, the methotrexate level dropped, the kidney eventually recovered. Now they have a delayed cycle 2, for instance. Do you give cycle 2 at the same intensity, same dose? Do you change the dose? Do you just switch to something else? I think the jury's still out on that, but 13 of those patients, they tried to, basically they re-challenged them, and they successfully eliminated methotrexate after that. So re-challenging is not a wrong answer. It's really a kind of a case-by-case basis, but that re-challenge showed that 13 out of those 20 patients eliminated methotrexate appropriately. And the last risk factor that they mentioned was renal dysfunction, and that kind of makes sense. If they have pre-existing renal dysfunction, that they can get the injury. I think a BMI greater than 25 was also a risk factor here. So supportive care for high-dose methotrexate-induced AKI. Remember, this is a supportive care to treat the complication, not what you already did to hopefully prevent it. You did your best to prevent it, but it still happened. Now, what's the supportive care? What we typically do, and I think we all agree, that we're going to increase the hydration, increase or maintain the alkalization. We might increase leukovorin dose, intensity, kind of frequency. We're going to monitor methotrexate levels. But then they still have that delayed methotrexate clearance. So then what do you do? And I think the second part of this conversation will be very interested in kind of looking at some of the mechanisms. So delayed methotrexate clearance in the face of a rising creatinine or decreased urine output is a medical emergency. It truly is a medical emergency. The problem with this phrase is that the rising creatinine is our surrogate marker, unfortunately. As you probably know, when you have a patient, let me just kind of give you a hypothetical case. You have a patient who has acute kidney injury, you consult a nephrologist, they come to you, after going through the chart, they come to you and say, well, 3 days ago, they had a hypotensive episode. The day before that, they got IV iodinated contrast. You gave them a dose of ibuprofen overnight. That's what caused this. But look what they did. They went 2-3 days back to be able to explain to you the rise of the creatinine now. So it's not that the creatinine is a bad marker. It's just not a very dynamic marker all the time. So it can be a lagging indicator. Sometimes it rises right away and you can tell. But oftentimes when you see it go up, the kidneys started getting the insult 2 or 3 days ago. And that's part of why this is an emergency. So look at urine outputs. That might actually happen, a decreased urine output might happen before, a positive net balance of fluids, weight changes. You have to look at those on top of the creatinine so that you can raise your index of suspicion. Close monitoring of serum creatinine and methotrexate plasma levels facilitate early recognition of delayed methotrexate clearance, and I'd argue that the latter half of the sentence is more accurate. Methotrexate plasma levels. If you have someone whose first methotrexate level is high, so higher than expected. The creatinine is normal. You have to suspect there's something wrong with the kidneys and wait a day or two and you'll see that creatinine rise. So that first level is high. That is most likely delayed elimination because of kidney injury. Severe methotrexate toxicity can occur when the plasma is two standard deviations above the mean expected elimination curve. Now, what does that mean? Dr. Ramsey will allude to this, and she'll show you a slide that shows what does it look like when methotrexate level is given as far as the elimination over time. We have an algorithm for that. If you're a floor nurse, you probably have this either online calculator or even something you have on, in your nursing station, where if you check a plasma methotrexate concentration, you then go back to that curve and you put an X and you see, does it land within two standard deviations of that curve, or is it above it? If it's above it, that's too high. That means decreased elimination. Intervention in this setting should occur within 48 to 60 hours from the start of the infusion to prevent life-threatening methotrexate toxicity. 48 to 60 hours. So what does that tell you? So if I have someone who I'm seeing there's a delayed methotrexate clearance, I'm seeing kidney injury, then treatment is indicated. Okay, so if I want to give them glucarpidase, the studies showed that if you delay it to after 60 hours, that has a negative impact on survival and kidney survival, so end-stage renal disease. What that doesn't mean is if you know what's going on and you know glucarpidase is indicated, wait until that 48 hour, so 47 hours, for instance. And I know no one does this, but what I'm trying to deliver, the message I'm trying to deliver is the sooner the better. So in reality, the sooner the better, the same for heart attacks and strokes. Prolonged exposure to methotrexate due to delayed elimination increases the risk of systemic toxicities. Obvious reasons, it's just the drug remains in the system. So how do you treat the condition? We talked about intensifying our supportive care, extracorporeal techniques. We'll talk about dialysis in a little bit. And then Dr. Rams will go over leukovorin, glucarpidase, and thymidine. So we talked about, I think what I didn't mention is acetazolamide. That's the only addition in this slide. Just basically mechanisms to try to improve the elimination of methotrexate. But remember, all of this just pushes methotrexate to the kidneys to enhance its elimination. Okay, it does nothing to the methotrexate itself. So the methotrexate is still a viable molecule. These measures just help us, salvage the other cells and push it to the kidneys so that the kidneys can clear. But you already have a diseased kidney. So then what do? Then you start thinking of how do you get rid of that methotrexate that's in the blood, so intravascular or extracellular. Leukovorin is intracellular. It works with glucarpidase, or in this case here, what I'm presenting is dialysis. Wideman is an author, published plenty on this scenario or in this field. And basically, she's discouraging dialysis. And in reality, this is high flux hemodialysis. It's probably the best way in that manner to eliminate methotrexate molecules. But the problem with dialysis is, to kind of mention a scenario, you're putting a catheter in. If it's a leukemia patient, our protocols are typically to move them to the ICU. So then you have them in the ICU, you put them on dialysis, the levels go down, and you often see a rebound of the methotrexate levels. So you have to do another session of dialysis, and sometimes more and more sessions to kind of maintain that level and kind of get it down to less than 1 or so. She did not recommend dialysis, and a lot of that is because we have an alternative. So if you are stranded somewhere, obviously I'm encouraging everyone to know how to get glucarpidase, who has it in your region. Do you have it on your shelves in your pharmacy? If not, if this happens, do you want to know how to get it? So it's really important that we really do that starting tomorrow when you go back to work. But if there's absolutely no means, then dialysis is one way to eliminate extracellular methotrexate. And that would be the conclusion of my part. I'll circle back at the Q&A session. I'm going to hand it over to you, Laura.
All right. Thank you. I'm going to talk through a few more slides. The first is on leucovorin. So leucovorin you give to prevent the myelosuppression and GI toxicity and the neurotoxicity that comes from high-dose methotrexate therapy. It is a derivative of tetrahydrofolate, so it looks a lot like this tetrahydrofolate THF up here. The leucovorin looks almost the same. If we go to the next slide, it highlights where that difference is. And the leucovorin, what it does is it bypasses this inhibition. So it goes directly to the folate cycle and restarts it inside the cell. So it really gets that DNA synthesis going again, as Dr. Kannan said earlier. The dosing of leucovorin is based on the serum methotrexate concentration and the time after the start of the methotrexate infusion. So you've probably seen the nomograms that show you how many grams of leucovorin milligrams you should give after your high-dose methotrexate. And so this is really necessary to restart that folate cycle in the healthy cells, as he described earlier. So another option is thymidine. This was tested as an alternative agent for reducing high-dose methotrexate toxicity, and it was used in a trial with leucovorin, but there has not been any great data to show that it's useful, and so it's not used very often clinically. This study looked at glucarpidase patients with thymidine or no thymidine after the start of the methotrexate. And really, the thymidine didn't help with toxicity at all, but the plasma methotrexate concentrations after glucarpidase decreased almost 99% within 15 minutes. And the methyl tetrahydrofolate also decreased 98% after the administration of glucarpidase. So really this study showed that glucarpidase was very effective. And so now I'll talk a little bit more about glucarpidase. And what glucarpidase does, it actually metabolizes that methotrexate. It is an enzyme that breaks it up into molecules that can be metabolized not through the kidney, but through the liver. So it gets rid of that reliance on the kidney to get rid of the methotrexate. Glucarpidase is always given with leucovorin because glucarpidase doesn't get into the cells. It only eliminates the methotrexate in the blood. The leucovorin is still necessary to get into the cell and restart that folic acid cycle. But the leucovorin looks like methotrexate to the glucarpidase, and so glucarpidase also metabolizes the leucovorin. So you want to wait about 2 hours to give leucovorin after the glucarpidase has been given, so that it can really focus on the methotrexate for those 2 hours and degrade that methotrexate. The indication for glucarpidase is to reduce a toxic plasma methotrexate concentration over 1 micromole in adult and pediatric patients with delayed methotrexate clearance. So that means that the plasma methotrexate concentration has to be greater than 2 standard deviations of the mean methotrexate excretion curve, specific for the dose of methotrexate administered. So I expect you all to know your methotrexate pharmacokinetics and have those 2 standard deviations of the dose you administered to your patient memorized. But it's not recommended for use in patients who exhibit no normal clearance. So you have to know, is this patient have normal clearance or greater than 2 standard deviations above the mean expected clearance? So what glucarpidase does is it takes that methotrexate and it breaks it into DAMPA and glutamate. And these are able to be eliminated by the liver instead of the kidney, and they are inactive. So it's not going to inhibit that dihydrofolate reductase enzyme anymore, and it'll let the leucovorin restart that folic acid cycle. So the differences between glucarpidase and leucovorin: the glucarpidase reduces the methotrexate concentration in the blood, whereas leucovorin actually gets in the cell and it combats that inhibition of the folic acid cycle. Glucarpidase has no effect on the intracellular methotrexate. So all that methotrexate that already got into the cell, it stays there, and it still inhibits that dihydrofolate reductase enzyme. There's no effect on the methotrexate levels in the CNS when you give the glucarpidase systemically. The glucarpidase, like I said, just hydrolyzes that folate and the folate-like substances, so the leucovorin as well, into the inactive metabolites. The leucovorin, it might not be as effective at high methotrexate concentrations because it's fighting with the methotrexate to get into the cell and to have to restart that folic acid cycle. So there have been several clinical trials of glucarpidase, and about 10% of the patients were younger than 12, and almost 10% were over 65. And many of the patients that had the levels above 50 micromoles or greater were pediatric patients. And those pediatric patients likely had osteosarcoma, where the patients with the methotrexate levels below 50 micromole per liter had lymphoma. So we'll go through one of these studies that showed that patients who had delayed methotrexate clearance greater than 2 standard deviations of the mean due to impaired renal function had a 97% reduction in plasma methotrexate levels within 15 minutes in all of the patients, and maintained that 95% reduction up to 8 days in 20 of those 22 patients. There weren't very many adverse reactions that occurred in these patients receiving glucarpidase, but there were a few: paresthesia, flushing, and nausea and vomiting. So next, I'm going to talk to you about how you determine whether your patient has a clearance greater than 2 standard deviations of the mean. So we created this tool called mtxpk.org, Methotrexate Pharmacokinetics, mtxpk.org, where you can load in your own patient's data and their dose, because that indication said it was specific for the dose that you gave your patient. And then you enter the methotrexate serum concentrations and the creatinine, and you can calculate their concentration over time. So first, I'm going to show you how to load the patient's data. When you go to the website, you'll start entering a patient's information, and you'll see a place you can put in an identifier. It is not saved by the website, and so you could put in PHI, but I recommend not. But you do need to put in the age, choose a gender, put in the weight and height of your patient. You can toggle this switch to make it pounds and inches if you prefer that over kilograms. And then you choose an indication. So some of the common indications have been preloaded. So like leukemia, 5 grams over 24 hours is pretty common. There's an osteosarcoma that's 12 grams per meter squared over 4 hours, and lymphoma protocol. But you can type in any dose that you want here. And for the leukemia, they often do a 10% loading dose over half an hour, and then 90% over the next 23.5 hours. And you can simulate any length of time that you would like. So once you enter your patient's data, then you move on to entering the methotrexate concentrations and the creatinine. So make sure that you enter the time after the start of the infusion for each measurement. So here for this patient, you can see the baseline. Of course, the methotrexate concentration before you start the infusion is 0, and the creatinine is 0.59 for this patient. Then the subsequent methotrexate concentrations are shown here, and you can see the creatinine rising. You enter all of those, and then it calculates this graph for you, this concentration of methotrexate versus time since the start of the infusion. It will plot the creatinine in the purple line, and the mean expected concentration is shown in the green line. The 2 standard deviations are shown in the green shaded area, and this red line is the line that if you're above that, you're above 2 standard deviations from the mean. The blue diamonds here are the glucarpidase guideline thresholds. So you can see, and then the black line, or the black line and the black dots are the individual patient's measurements. So we put in the 4 time points here for the methotrexate concentration, and you can see that the curve fits that data pretty well. And for the first 3, the patient was under the glucarpidase guideline thresholds, and then at the 4th one, at 48 hours after the start of infusion, they were just above that glucarpidase guideline threshold. But they were above the 2 standard deviations for the whole time there. It also calculates the time to elimination. So a lot of times the concentrations that are needed before discharge are 0.2 micromolar or 0.1 micromolar. And so it tells you how long it'll take this patient to get to those elimination thresholds. It also calculates the area under the curve, which is just the area that's under this black line, and it is the total exposure to methotrexate. You can download a report, and it'll provide all the graph and the saved information. All the information you entered about your patient will be there. So it's a fairly new tool, but it has been used by about 2,500 users over the last several months, and in 60 different countries. So it is being widely used, and I hope is helpful. There's a contact us feature that you can use if you need some help using the website.